So we have three excellent speakers. I'm going to read their bios for you briefly. Dr. Julie Bloom completed her medical degree at the Baylor College of Medicine, internship residency at Boston Children's Hospital, and she's a professor of pediatrics at Baylor College of Medicine, director of the immunization project at Texas Children's. She's led multiple immunization educational programs, so really excited to have her here as we've done over this past year with our colleagues at Baylor. Dr. Kathi Rosen is a general pediatrician at Sandpoint Pediatrics, Virginia Mason Franciscan in Seattle. After her first career as an engineer working in medical devices, she attended New York Medical College, not far from where I am right now, and then went on to train in pediatrics at UW, Seattle's Children. She has a daughter in high school, and daughters in elementary school and high school, and ecstatic that her 11-year-old got her first COVID vaccine last weekend. So hope I didn't steal your thunder there, Dr. Rosen. Dr. Jill Walsh received her medical degree from Loyola Stritch School of Medicine in Maryland. She completed her pediatric residency at UC Davis, and she currently serves as the department chair of Women and Children's Services, Pediatrics, Neonatology, Obstetrics, and Gynecology at our Mercy Medical Group in Sacramento. And if I'm correct on all of that, I will. Now, who do we have up first?
Dr. Boom.
All right, great. Take it away, Dr. Boom. Thank you for joining us.
And thank you so much for that lovely introduction. And I'm going to go ahead and share screen. Again, thank you for the lovely introduction. It's a pleasure to speak to your group. As the director of the immunization project at Texas Children's, I've made a concerted effort throughout my career never to be a speaker for pharmaceutical companies, so I could speak without conflicts of interest. I will share that my grant funding comes from CDC. I'm the Houston site PI for the new vaccine surveillance network. In general, I will try to use generic names when possible. However, we only currently have one specific product available for the vaccination we're talking about today, which is COVID-19 vaccines for 5 to 11-year-olds. So first, I wanted to kind of address what we have seen at children's hospitals, but what has been projected on the television. And undoubtedly, I think we've been much more familiar with the images on the right, which is elderly persons becoming sick and dying with COVID-19. Of course, that has included people in their 60s and 50s and 40s, but unlike the image on the left, and that is a teenage boy who has been in our ICU, was in our local newspapers for severe COVID-19. And if you speak to our ICU physicians and other pediatric intensivists throughout the country, that this has been a real phenomenon for them also. And if you look at how COVID-19 has really shifted the age patterns, we've really seen shifts, especially with the recent Delta wave. So with this graph, this is a CDC graph looking at age. And I want you to focus most on the gold lines, and those represent our younger age groups. So the fine dot 0 to 4, the solid line 12 to 15, and sort of the medium gold dots 5 to 11. And if you will look back in our cases about a year ago now, when we had sort of the holiday wave, children were the lower groups to have cases. But with the summertime, we saw that children were much more likely to be affected. And so how has this really happened? Well, what we've done, and we've done a wonderful job of vaccinating our 85 plus, our 65 plus, are getting more vaccinated. And what we've been left with a larger vulnerable population of younger persons. And we've seen quite a bit of transmission in this younger age group. And currently they make children in the 5 to 11-year-old age range make up about 10% or 11% of the cases that we're seeing. And so looking at hospitalizations also by age group, just among children, you can see that 0 to 4 are highest. And I'll tell you 0 to 1 is very concerning for illness. Our 12 to 17-year-olds are next, and then our 5 to 11-year-olds. So we do have a vulnerable population in our children. They are certainly transmitting disease. And looking about severity, this was a study looking at children who were admitted, seen in the ER or admitted. And about 10-11% of children are getting hospitalized. And importantly, 31% of those children are going into the ICU, requiring severe care. So about 1 in 3 chance, if you go into the hospital, you're sick enough to end up in the ICU. We do know that chronic conditions are playing into this, but about 1/3 of kids don't have a chronic illness playing into this. So we do know they get sick, and unfortunately, we're seeing these children die. And these are numbers just from yesterday, looking at death in children. And for children 0 to 17, since the beginning of the pandemic, we've had 700 children die. And at any other point, if we had had 700 children die across this nation over the course of a year and a half, that would have, or almost, really a year and a half, that would have just made national headlines. But of course, we've had many more times that in our elderly age groups dying. But in the United States, children don't die. They're not supposed to die. And 700 children is a remarkable number of children. And just to think about the number of children in 30 persons classrooms, that's like 25 classrooms of 30 children each that are now no longer in existence on this earth. It's 2 full 747s of children. Lots of children have died, and we shouldn't just be minimizing that. There's also kind of a myth about long COVID that, oh, my child may get sick, but they're not going to get that sick. And there is been a kind of a meta-analysis, if you will, of all of the studies looking at long COVID, and we've had very varying results. And if you talk to our various cardiologists, pulmonologists, we are definitely seeing children with prolonged chest pain. We're seeing children in some of our neurology clinics with prolonged headache, with prolonged fatigue. It does seem to be hard to separate those symptoms from some of the psychologic symptoms that we're seeing in children from COVID, but certainly long COVID is occurring amongst children. And then finally, MISC. Still to this day, there are many parents who are simply unaware that we are seeing a phenomenon in children several weeks after their COVID infection. It can be an asymptomatic or symptomatic COVID infection. These children come into, could go to their pediatrician's office or an emergency room with fever, vomiting often, and diarrhea. Some of these children look like they've had appendicitis or are having it and have even had their appendices removed. I think we're learning more and more about how to catch this early in our emergency departments. And if children have a certain set of symptoms, they're coming in, getting a whole panel looking for markers of inflammation. Currently, and again, this is data as of yesterday, we've got over 5,500 kids across the US that have come in with this potentially life-threatening condition. 41 of these children have died across the nation. So this is a severe condition. There is a similar condition in adults, but it's certainly more common in children. We do know that kids are at least as likely as adults to get sick with COVID. Recent seroprevalence estimates from CDC show that almost 40% of kids have had some exposure to COVID-19. So we do know that it's not that the disease doesn't exist in them, it certainly does. Early on, we thought they were more likely to be asymptomatic, and we're certainly picking that up, but we're also picking up symptomatic infection. So we were thrilled at Texas Children's last week to be among the first to vaccinate across the country. And as soon as Dr. Walensky added her signature of approval to the ACIP recommendations, we were vaccinating 7 a.m. the next morning. These are some of the pictures from that vaccine event. The little boy, the second from the left, was actually a child who's currently has cancer, but getting better. And he was so excited, as was his brother in the middle, to get vaccinated so that they could be protected from COVID-19. Just briefly to remind you all about the study of COVID-19 in children. And the Pfizer-BioNTech study was a phase 2, phase 3 trial. It involved 2,268 children. They were randomized 2-to-1, so 2 children would get vaccinated for every 1 control child. And we were very happy to see how these results turned out as far as side effects. And the slides are a little tough to look at, so I want you to look at the first row and, for instance, look under fever. And the children in the left bar, those were the children in the 5 to 12-year-old age range. And you can see that they had less fever less often than their comparison group, which were adolescents and young adults in 16 to 25. Similarly, fatigue was 39% in our 5 to 12-year-old age group, and it was lower than we were seeing in our young adults who were 16 in the 16 to 25-year-old age group. Headache also less common, chills less common, muscle pain less common. So very nice to know that they, didn't have serious side effects, and the ones that they did have that we were seeing in older age groups, even a little bit less common. As far as serious adverse events, they did not experience any in this study of over 2,000 children. We just did not see any serious side effects. And not to harp on this, but they did have an excellent immune response. This is not a surprise to pediatricians. Children in the 5 to 11-year-old age range do have strong immune systems, do make good responses, and importantly, it was not inferior to what we were seeing in the older age groups. So what we do when we introduce vaccine to lower and lower age groups, we do what are called immunobridging studies, so that we can say, well, if we can compare how well this group's immune system works compared to older groups, and these children developed an equal, if not a little bit better, immune response. So here we are with the pediatric vaccine doses available. There are some important differences that I want to point out to you. The dose that the children are getting is from a vial that contains an orange cap. This is very different than the 12 plus vial that is a purple cap. And the dose that these children are getting is 10 micrograms, and that's 1/3 the dose that the older group is getting. It's also given 21 days apart, just like the 12 plus formulation is. It is a different buffer formulation, and that does lead into different storage and handling requirements, which are a little bit easier than we were seeing with the adults. So again, if you're starting to vaccinate in your location, be very careful to separate your 12 and up, which is the purple cap vial, from the vaccine administrators using the orange cap for 5 to 11-year-olds, because as the slide points out, the micrograms in the 5 to 11 is 10 compared to 30 in the older age group. Both vaccines have to have a diluent, and my understanding from our folks who are drawing these up, the amount of diluent that was being provided by Pfizer is much too much, and you do discard it after a single use, but you drop 1.3 mLs and you add it to the 1.3 mLs in the vial, and the amount you inject into the child is 0.2, and that's different than the adult, which is 0.3. So the diluents amounts are different, and the volume that's actually going into the arm of the patient is different. Doses per vial in the orange top is 10 compared to only 6, as we became very familiar with in the 12 plus or purple top. As I mentioned, there's this sucrose buffer, and it is allowed for different storage and handling requirements. And this is from our local health department has put together this sort of visual, if you will. And like the adult formulation, the pediatric is stable in the ultra cold freezers for 6 months. There is no role for regular freezers. It's stable in refrigerators for 10 weeks. And once it has been diluted, it's stable at for 12 hours at room temperature, which is longer than the 12 plus formulation. So we're glad that it's a little bit easier to use. So I was asked to speak a little bit about myocarditis. And it's important that everyone understand that while this has been sort of advertised, it is very rare. It's a very rare phenomenon. And CDC, the information chair, the CDC, and the VRBPAC committee for the FDA, it was very specific. And I think that individuals have gone to great length to look at this. And they point out that there is classic myocarditis. And classic myocarditis is more common in adolescents. It does increase in adolescent boys into young adulthood. And that is the classic myocarditis that I learned about in medical school. You may learn about it in your medical training. It can be caused by viruses, bacteria, toxins, drugs. And they compared that to other forms of myocarditis. And they compared it to COVID-19 related myocarditis, which is a pretty rare phenomenon. The myocarditis that we see with MIS-C, which is very common, and that we're seeing with vaccine related. And vaccine related myocarditis is most like classic myocarditis. And they've been able to look at the reports through the VAERS system. They've been able to do full analysis of some of these. In some of these VAERS reports, there was simply incomplete information. And over 600 of those, they're still waiting to get information. But they've looked at 877 of these that met the case definition of myocarditis. About 829 of these children were hospitalized. At the current time, 3/4 of those patients have been completely discharged and resolved. Of the deaths that had myocarditis related to it in VAERS, they have dug through those cases and none have been found to be related to COVID-19 vaccine. None have been found to be related. As I mentioned before, this vaccine related looks like classic myocarditis, and they've looked at the ejection fractions of these patients and they quickly return to normal. And these children have had extraordinarily good outcomes. And the patients have even not only called the families, but they've called the doctors. And overwhelmingly, these doctors report that these patients are making recovery, even return to full activity. So with this information and the fact that this is very rare, they've made the determination that the risk after receiving an mRNA is lower than we would see associated with the disease, SARS-CoV-2, the disease, and that with MIS-C in children. So myocarditis and risk of that should not be a reason that parents choose not to vaccinate. And unfortunately, there's misinformation about this, but it's really up to us, the medical personnel, to make sure that we're setting the record straight with that. So with that, I know we've got some other folks with information they'd like to share, and we'll be happy to take Q&A.
Yes, so why don't we move forward? That's absolutely spectacular. Thank you. And I have a question, but I'm going to hold it. So Dr. Rosen.
So I'm actually going to talk a little bit more from the general pediatrician's perspective, just being in the office, since I am a general pediatrician here in Seattle. These first slides. So Dr. Boom's talk was great. I learned so much listening to her as well. So I really appreciate it. I'm actually going to skip through some of the things that she had already covered in so much better detail and better framing. The one thing on the right here is I'll comment that MIS in children, that 5 to 11-year-old age group looks to be the greater risk as well, just by age. This impact on kids directly, I think Dr. Boom did an amazing job, so I'm actually not going to linger here. I will just say that beyond the medical aspects, the burdens of COVID on kids really extend beyond the numbers that we've already discussed, and we need to keep that in mind too, regarding family, caregivers, work loss, missed school, et cetera, mental health crisis, disordered eating, et cetera. So big issues that are pandemic related. So we need to do everything we can to help move out of that. Okay, couple pearls that I sort of keep in mind as a general pediatrician that came out of that VRBAC meeting about the 5 to 11-year-olds is that they ran multiple scenarios using conservative estimates and ultimately decided that the benefits of COVID vaccination in the 5 to 11-year-old age group outweighed the risks. And the important thing to remember is that VRBAC really looks at the individual child more so than including any other factors around family or community benefits as well. So even when you're thinking about the individual child in front of you and the parent is thinking the same, the benefits do outweigh the risks in terms of vaccination. And with that seroprevalence that Dr. Boom talked about, also talking to families about how COVID vaccine is safe, even if a kid has had a COVID infection in the past, is also helpful. One of the pearls from the ACIP meeting that came after, was that prior infection by itself does not provide broad protection for children. So we still need to be vaccinating kids, even if they've had known COVID before. And the other thing to keep in mind is that MIS in children typically occurs after asymptomatic or mild infections. So you can't say that you can't predict who that's going to happen in. ACIP had this slide on the bottom talking about how COVID-19 is now vaccine preventable. So we can actually do this work, and it's going to take all of us on the ground to do it. Okay, here's where I'm going to linger a little bit because I think it might be more helpful to folks who are having these conversations with parents. These are just some of the questions that I get more routinely or I've gotten recently leading up to the 5 to 11 year old EUA being available or being approved. What's the rush? So that I think comes back to the presumption that families think kids don't necessarily get as sick as they actually do or can. And the point I try to make is that you really want your kid to get vaccinated rather than infected. The response to the vaccine is predictable and understood and safe, whereas there's a lot of unpredictability for kids who end up getting infected with COVID-19 or with SARS-CoV-2. So get vaccinated, not infected. Don't kids do just fine? This goes back to the data that Dr. Boone shared already in such detail. Is the vaccine safe, right? Ultimately, this is what parents feel, I guess, more unsettled about. And the biggest thing to say is that, yes, like it is safe. An infection with SARS-CoV-2 or COVID-19 has higher risks. And so when we're supporting parents in making this decision, these cusp kids are also what we get a lot of calls about or a lot of messages about. Should a parent of an 11-year-old child wait for their child to turn 12 in order to get the higher dose? One of the local infectious disease docs here was quoted in the paper saying, if you wait, it's sort of like saying, I'm going to drive to grandma's house, but I'm not going to wear a seatbelt for the first 50 miles. So you want to get vaccinated sooner rather than later and get it with the dose that's available to your child for the age they are at the time of vaccination. Another question comes up about, can you get the 5-year-old dose early for a 4-year-old, somebody who might be 4.5 or turning 5 soon? And the recommendation there is no, is to wait for the dose that's available to your child at the age they are. And the dose is actually expected to be lower for those 2 to 4-year-olds as well. A big question that comes up is, shouldn't it be different dosing for my small 12-year-old daughter as compared to my fully grown 16 or 18-year-old son? And the education to share there with families that seems to really make a difference is helping them understand that vaccines are really developed and built based on the maturity of the immune system and the immune response overall, rather than the size of the person. So yes, the 12-year-old smaller daughter should get the same dose as the 16-year-old larger son. When you're having these conversations, motivational interviewing is something that we use in lots of ways in practice. And here for COVID vaccination, I think there are 3 of them that tend to be most easy to use in these conversations and possibly some of your more helpful versions. And as I understand it, motivational interviewing and talking about vaccine hesitancy has been something that's been covered in this kind of talk before. So I'll be quick here, but the open-ended questions are really helpful. So asking families, what are your concerns? They're coming from very, very different places sometimes, and you can't predict where they're coming from. So asking that to start, letting them share where they are, and then affirming that they clearly want to do what's in the best interest of their child, and so do you, which is why you're having this conversation. And then asking that permission to share. Can I share with you why I think this is so important? Can we talk about this further? And then share a strong personal recommendation. So just yesterday in a visit for a 3-year-old for short stature, I was talking to the parents about the 5-year-old, maybe 6-year-old sister, and had they moved forward on the COVID vaccine for her. And so we had a whole vaccine conversation that used every one of these motivational interviewing points. And it wasn't even her visit, but it was an opportunity to help parents gain more information and hopefully build some more confidence. So remember, when we're talking with families, when we're thinking about this for all the work that we're doing, we're not really choosing between vaccinating or not vaccinating against COVID. People are choosing to vaccinate or eventually get infected. And that's really the comparison that you need to be keeping in mind there. And ultimately, it's safer for children to get vaccinated rather than infected. And then I think a lot of us on this call, either as pediatricians or family practice docs or OBGYNs, are seeing women when they're pregnant, and they're not necessarily seeing their own regular doc. So we need to be doing that work to help pregnant women build confidence in getting themselves vaccinated as well. Burnout is real. People are tired. So one of the things that we can all do and support in different ways is just any extra, I say work, but it's really quite joyful in a lot of ways, with getting people who are ready to be vaccinated actually further down that and vaccinating them. So this is a picture from last weekend, that first day of, or one of the first days of vaccinating 5 to 11-year-olds here in Seattle. We were all Virginia Mason and pediatric providers. The two folks on the far right are actually retired, and they've been coming back in and been doing a lot of work over the past almost year vaccinating. We saw our patients there. We saw our kids' schoolmates there. It was joyful. Batman was there and Snow White was there, and they had balloons, and parents were crying and shaking. And it was just so joyful and such a positive antidote to all of this fatigue that we're all feeling as well. So where you can, try to sneak some of that in, because it can be really great as well. And that's all I've got. So we can move on, Dr. Greensweig. Yeah.
Thank you. Thank you. I think what we're going to do is move to the panel. Tom, you're here. And Jill, you may have some comments, and let's move those to the panel if you have thoughts. And we don't have a lot of questions so far. I have one or two, but Tom, general comments, or Jill, general commentary?
Yeah, I would turn it over to Jill and see if she had any comments or reinforce any of the messages. Jill.
I have several. One is, it was very interesting to see, because it's not well publicized, that 0 to 1-year-olds are at most risk for severe infection. And, I think one of the other strategies we can use is that, many 5-year-olds and children, we need to protect, similar to the flu vaccine for children who are less than 6 months. I think one of the strategies we can use is the importance of not only protecting your own child, but protecting your younger siblings against getting COVID vaccine. And I think that that's another, that highlights another real important topic to discuss, is protecting your babies, right? And so I do think that, because parents don't think about that. Parents don't think, well, my 9-month isn't going to school, they're at home, but yes, your school age children can be bringing it home. And so I think that's another area to highlight. And, certainly, as far as Dr. Rosen's comments, I completely agree with everything she said. She gave a great presentation, both of you guys did, but just partnering with the families to talk about it and asking those open-ended questions, and not being portrayed as a bully, but really a partner in decision-making and trying to waylay fears. And, certainly, I think, Dr. Boom, you gave us a lot of really good information that is, we can share that information and share the facts with patients or with parents to really help to convince them that giving their children these vaccines is so important. Because a lot feel like, well, natural immunity, right? I mean, this kind of thing with flus and other kinds of things, natural immunity is best. And in fact, in this case, it's not. And especially when we're talking about the multi-system infection and how serious that can be. And you just don't know who's going to get it, even if they have very mild symptoms. So those are all really key points that I think we need to take home and share those with our families as we talk about the COVID-19 vaccine for children 5 to 11.
And we've developed a one-pager at Texas Children's that we're giving out at all of our registration points, because we know whether you've got a 12 or 13-year-old checking in or a 2-year-old checking in to an appointment, be it a well child or a specialty appointment, they often have a sibling in this particular age group. And even if the mother doesn't have a 5 to 11-year-old yet, we need to explain to them now, this is a safe and effective vaccine. We have confidence in this, and billions of doses of COVID-19 vaccine have been given, and it's safe. And we need to really put that out there so that parents see this. And so, because eventually, and we hope in the spring, we'll have vaccine for 6 months and up. And I think that we'll really be able to make a big difference in the pandemic at that point.
Can we borrow your one pager?
I will do that.
Send it to me.
And I will post it. And hopefully you can share that link. I'll try to.
Yes, that would be great.
Yes. There are two questions in the chat. One is, do you recommend children get COVID-19 vaccine and flu vaccine at the same time? Takers?
Yeah. Oh, go ahead.
So absolutely, you can give any vaccine that is due, including flu vaccine or any other pediatric vaccine, at the same time as COVID vaccine. Early on, there was a 14-day window on either side of it because it was a new vaccine. We wanted to make sure and know what the side effects were around COVID-19 vaccine. But again, millions of doses been given. CDC has looked at all of this data, and they did not see any concerns about other vaccines. So they lifted that months ago. So feel confident if your child needs the 4-year-old vaccines or the 11-year-old doses or anything else, do it all at once. It's fine.
You know, one of the interesting questions, I sit on a few school boards and advising on COVID, and they just had an outbreak at one of the schools last week, just as they were getting kids registered for the vaccine. So, you know, the big question came, well, if my kid's been in exposure, you know, do I get them? Should I have them just get the vaccine? There's all these sort of one-off kind of questions like that. And I mean, you know, how do you answer that one? I mean, you've been exposed, should you get the vaccine?
If you are currently in isolation for quarantining, isolation after disease or in quarantine,
Then it's just, you're done, right? So
you have to stay home.
you're not going out to get a vaccine because you've been exposed. Right. Yes, it was one of these like school shutdowns, and everybody, it was a little chaos, but you get a lot of questions. My daughter had it, and then, how long do I wait till after she had it? Those are the other big questions.
And that's one of the benefits. So as soon as you're done with your quarantine or isolation, you can go get vaccinated. You do not have to wait any longer after
These
that.
are good on the fact sheets that we just need to have these, little things put down. I like the ideas, like when you're vaccinated, you're controlling the environment. When you're just getting I think that might have been you, Dr. Rosen, that said that, the vaccine's a controlled environment. The virus, you just, all bets are off. You don't know what's going to happen. So it was a nice way to put it, I thought. A lot of this is, how do you communicate to folks about these things that are kind of short to the point, but respectful and thoughtful.
And back to your school exposure. So for kids who are vaccinated, then there is an exposure. Vaccinated kids don't have to go stay home and all of that sort of stuff. So
that's the big news. Yes.
Really important. And
these young kids, right, they can now take, more safely, feel comfortable taking their masks off. They have lunch in the lunchroom and all these sorts of things, depending on what every school has different regulations, but after school activities now become available to many of them where they weren't before. The mental health issues are dramatic here.
There's one more question which says, my patients have questions about risk of autoimmune disease after mRNA vaccines. Please help with any data or evidence regarding that.
So I'm happy to generally take that. So to date, whether in adults or in our 12 plus adolescents, there has not been any safety signals about autoimmune illnesses that have been triggered to date. Mm-hmm. And the COVID-19 vaccines have been the most safety monitored vaccines that have ever been put forth in the history of the world, period.
It's true.
It's
so true. I know I keep telling people that nothing has had more monitoring.
Nothing. Now that we've given billions and billions of doses, we're able to look for very rare phenomenon. And that has not been a phenomenon that we have seen. And so we would not expect to see that. And Paul Offit loves to say, the vaccine can only cause what the disease could cause. And so the disease does not cause autoimmune illnesses. And so we are not going to see the vaccine cause that.
That's a nice way to say that. The worst it can do is do something that COVID does. But
that's exactly right.
I guess I would ask, when this is more of a major structural question, and I think what we're going to see, just like we saw with adults, right now we have people coming in. It's that first, it's like the first 5 pounds on your diet, it goes easy. But it's going to be the next group of hesitant parent, not the vaxxer group, but the biggest group are the hesitant group. And there's a spectrum of hesitancy, obviously. We just got the early adopters, right? They came running in, and those are the ones you're seeing, and it seems great. We know it's going to happen in like 2 or 3 weeks, right? It's going to go down, and we're going to go, and a lot of that has to do with communication, access points, just being in the journey with them, listening, calling them back. I mean, I know, Dr. Walsh, you've thought a lot, everyone has. So maybe just quick points on that thought, Dr. Walsh, and then maybe Dr. Rosen, and wrap up with Dr. Boone. So Dr. Walsh.
Sure. I just think that we need to continue to have these discussions every opportunity we can with our patients. And, certainly there are going to be some that are going to be adamant they do not want it. But I think there's going to be a fair number that are worried it's a new vaccine. I mean, that's oftentimes the biggest concern. And I think, the safety issues with the fact that this has been the most monitored vaccine ever given in the history of the world is really helpful to say we've given it to billions of people in the last year, and it's a safe vaccine, and it's been studied.
I guess I would push you a little, I guess we're going to say that to everybody, but as we hit the hesitant group, we're going to have to be a little bit creative, right? I mean, maybe it's a reach back out after we've already had that conversation. I'm saying, what systems in place can we do when we've bumped into folks that just they heard it, but they weren't moving? And I guess the question is, do we reach back out to them again? Do we create new venues to do that? Sorry, go ahead, Dr. Walsh.
I think there certainly is ways we can reach. We certainly have the ability to figure out which of our patients have received the vaccine or 5 to 11. We already have built that in our system. And so we can certainly monitor that and reach out to those patients and just try to check back in with them. It's been given for a while now, we've not had any issues. I think one of the things that's really helpful too is that for 5 to 11, if you look at the side effect risk, they have the least number of side effects than anybody else who's gotten the vaccine so far. So I think we can talk about that. We can talk about, again, focusing on protecting your younger siblings because the vaccine not available for them. So I think there's a few key points that we can help encourage parents who are concerned about getting the vaccine initially. I think there's some real key points that we can help to get them willing to give the vaccine.
Dr. Rosen, any thoughts?
Yeah, I think I'd just add that it's a journey, right? I think at least me often in the room. Yeah, I want it.
Journey, Dr. McGinn.
Totally. And I want it to be like, I said the key thing and they said, yes, let's do it. And that's not how it's going to happen.
I've been trying to say the key thing to my kids and it never happens. So
Exactly. I think, with vaccines prior to COVID, there was more and more vaccine research done. And one of my mentors here at Children's has done a lot of that research, Doug Oakle, from an ethics and general pediatric side. And, that they were sort of saying, hey, introducing it in a presumptive format was an important part of vaccine uptake. We can't really do that the same way on this one. We sort of need to tackle it with where it is right now in this, tell me what you've been thinking, ask those open-ended questions and join the journey, right? And then take every visit that you can as another opportunity, whether it's a sibling, whether it's a, laceration, and kind of check in and chat, talk to schools, right? Kind of get yourself out there. It'll take some time.
We need to be, maybe Gary and I, and working, with you, Dr. Walsh and Dr. Rosen, and to think of what we do to facilitate the journey. Because I think we may have, this is a systems question. How do we re-engage them to make sure we're kind of gradually coming along with them? Whether it's a text message after a visit, you have any more questions, please set up a virtual visit. We'll just talk vaccine. We'll just have a vaccine chat for 5 minutes. what are the system things that we could do to create the journey? Because a lot of our healthcare is just like, oh, you showed up at the office, I spoke to you, and you left. We didn't really connect the dots. Anyway, I should stop. But
no, I
Dr.
think
Boone,
from a systems perspective,
sorry,
I think
Dr.
that's okay. I think pediatricians are actually pretty good at this, and a lot of people who see kids regularly, because we're often saying, oh, it's not your visit, you're well checked, but you're due for your meningococcal vaccine. Let's get that taken care of today.
Right.
So that's one piece that's already there that we need to build.
I think what she's trying to tell us is us internists and family medicine docs, we're episodic in care, but family medicine is much better than internists.
No, I mean, I think when you're seeing the family, you've got a huge opportunity there. Dr. Boom, I know you had a comment.
Sorry, Dr. Boom, go ahead and we'll close out.
I want to make 2 points. So in Texas Children's, we have paired with all of our local independent school districts, and whether it was 12 and up or 5 to 11, we've been doing large town halls with all of these ISDs and paired with them. And we've also been working with some of our large faith-based organizations throughout our community. I know one last night had over 4,000 listeners.
Wow.
We had physicians of various race and ethnicities on those presentations to help explain and dispel myths. So I would encourage you all, don't underestimate your sphere of influence. These folks want to hear information from people they trust. The second thing I'll tell you that we've been working on, and it's really getting legs, is we were able to purchase just a little video app that goes onto a cell phone. I think it's called a vlogger, and you video and audio record. And we've made some nice messages, and we're working on sending those out via text messages to our families. And it will go, say, from Dr. Rosen to Dr. Rosen's patients. And it can be a 60-second message about her perspective on COVID-19 vaccine going out. And given that we've all moved into the TikTok world and short video clips, it's a nice way to get education from your doctor to your patients about something important like this. I know many of us have access to MyChart and other entities, and I encourage you all to work within your system to come up with unique ways to get specific messages to specific patients.
All right, I think that's a great challenge for us. And Dr. Walsh is heading up our new group. So I think, which, by the way, thank you for your leadership in that space, Dr. Walsh, and working with the health system to try to, promote and standardize some of what we do in pediatrics. So much appreciated. I thank you. What a great discussion. Such an important conversation. And thank you, all of you, for your leadership. You've been doing it for a while, and now you're really on the spotlight. So we're so grateful to have your expertise in CommonSpirit and our partnership with Baylor. So, Gary, any last words before we wrap up?
No, absolutely great. I want to touch base with you, Dr. Boom, afterwards about shelf life. And once you open the vial, is it still 12 hours or is it shorter?
My understanding is it's 12 hours, and you must use the specific diluent provided which comes to me from Pfizer to our state to us.
Well, we may check in with the three of you in maybe about a month. What do you say, Gary? We'll have another session and hear about
this is absolutely great.
Partnering with our local
your leadership.
Okay.
I think the closing comment is it's not a choice to be vaccinated or not. It's a choice to be vaccinated or get sick and get infected. And I actually read that last night on your slides, Dr. Rosen, and I said, hey, look at this. My wife was nearby. I think that's really very clear. So thank you. Thanks, everybody.
Thank you.
All right.
Great.